Hello everyone, welcome to part 4 of unexpected hepatic disorders. I did not plan to actually go till part 4 about it, but I was unable to record, for such long times. So we were studying about the clinical signs and symptoms of chronic liver disease, of which we had started with ascites. So this was the last slide if you remember. So yeah, we'll be just going through that again. So let's start. Pick a nice color. So we were talking about ascites. Ascites is one of the hallmarks of CLD. It is protuberant abdomen. What else? Diaphragm, as told earlier also, diaphragm is displaced upwards. So there is respiratory distress. Then there is also one entity known as the sympathetic pleural effusion. Sympathetic pleural effusion. What is this? This is the buildup of sterile fluid. So why does sterile fluid build up? Why is there pleural effusion? Because of liver. It is because there is increased permeability. So how does permeability of vessels increase? It increases because of increased inflammation. So whenever there is inflammation in surrounding tissue, what happens is inflammatory mediators are released. So since liver is having inflammation, so inflammatory mediators are released, and those inflammatory mediators somehow reach the capillaries to the nearest lung, which is the right lung. So what happens is somehow it causes increased permeability, and that's how there is pleural effusion, which is sterile, which is not infected, and that is known as sympathetic pleural effusion. So now what about the management? So if the ascites is mild to moderate, what do? We just start on fluid restriction. We start patients on salt restriction mostly, right? Then we also start patients on diuretics, right? So for diuretics, if you ask me, that according to TINTINALLIs, they say that please do not give Lasix. Furosemide is not given. Why? Because it causes over-diuresis. So why do we give? We give a milder diuretic. So that is Aldactone, Spironolactone. So Spironolactone is preferred over Lasix. How much do they give? It ranges from 50 to 200 mg per day in divided doses, right? Also, if you cannot give spironolactone, or if you want to add on another one, then you can give amiloride. So what is the dose for amiloride? It ranges from 5 to 10 mg per day. Then large volume. Mild to moderate ascites, I've told you what we do. Now let's say if it is a large volume ascites, gross ascites, right? If the patient has respiratory distress, ascites, right? Then what do? We do paracentesis. We do ascitic tapping. Ascitic tapping, right? Now let's see. If patient is a known case of CLD, then the hepatic functions are deranged. So PT and INR may be deranged. So we have to take care of this one part. Also, how much fluid can you remove from a large volume ascites is very, very controversial. So there is American Association for Study of Liver Disease, AASLD, American Association for Study of Liver Disease. They say that tapping is safe until there is evidence of fibrinolysis. So evidence of fibrinolysis is in the form of easy bruising, right? 3D bruising is actually written in the book. 3D bruising, oozing from the IV sites. So whenever we secure a cannula, if there is oozing from IV sites, right? If there is evidence of DIC, or if a patient has known to have DIC very recently or something like that, then it is very unsafe. Otherwise, tapping is safe in CLD patients with large volume ascites, right? How much can you remove fluid? So they say that you can remove any amount of fluid. Just remember that you have to give IV albumin. So how much albumin you have to give? You have to give 6 to 8 mg per liter of fluid that you remove. So 6 to 8 mg per liter of fluid removed only for volumes more than 4 liter. Honestly, this does not happen in our ER. It is very, very difficult to take out 4 liters of fluid without the patient going into shock. As far as I have observed in our ER, we first take the patient on albumin. See, one bottle of albumin in our ER, one bottle of albumin is 100 ml, and that is 20%, right? So that is 20 grams actually. So 20 grams of albumin is present, and we start on albumin first. So we give the first half, that means 10 grams of albumin we will give, and then we start tapping. So that is known as under the cover of albumin. And after the tapping also 10 grams is left to be given. So total 20 grams we will give to the patient. And still the volume that is removed is 3 to 4 liters. But I haven't seen volume being removed more than 4 liters. I think it is not for our subpopulation, but yeah, so this is how it is. Then SBP is another complication. SBP is spontaneous bacterial peritonitis. So spontaneous bacterial peritonitis, it is the most common life-threatening complication. All the other complications are not as life-threatening as spontaneous bacterial peritonitis. 1 year incidence is roughly 30%. Recurrence is 44%, right? Survival rate is very low. Survival rate of first episode is 68.1%, which means only 68% of patients are going to survive, rest are going to die, right, at 1 month. And it is just 30% at 6 months. Survival is only 30%. Only 30% of patients are going to survive after 6 months. So this is about the mortality, survival rate, etc. What is the clinical features? What are the clinical features, signs and symptoms? So it has fever, diffuse abdominal pain, and tenderness. So whenever a known patient with CLD comes with fever, abdomen pain, and tenderness, first thing you should think about is SBP, right? Very, very, very difficult to manage. Any of these features can be absent also. Any of these features can be present also. So it has, like very non-specific actually. So patient who have already been diagnosed with HE, hepatic encephalopathy, or patients have active bleeding which we had to stop when the patient arrived in ER, or if the patient presents with fever in a known case of CLD plus ascites. Plus ascites means there is fluid buildup already. These patients should mandatorily undergo ascitic tapping, diagnostic ascitic tapping, right? Now, initial treatment. So what is the initial treatment for these? There's a table. Let's look into that first. There's this table. Wait, I'll look into it. I was reading about endocarditis the other day. Chapter number 80, right? Table 80.2. Page number 520. Yes. So this is the table we were talking about. So diagnosis and treatment of SBP, right? So how do we diagnose it? We take ascitic fluid. How much do we take? 50 ml for cell count, gram stain, culture. Transfer fluid to culture bottles at bedside for best results. Now there are 3 things how they can tell you that the patient is having SBP. One is the WBC count. If the WBC count is more than 1000, So if the WBC count is more than 1000. So this was one thing. Then the other is that if the PMNLs, nuclear leukocytes are more than 250, or if they on gram stain there is bacteria. Any one of this will help you to diagnose SBP. What is the empirical treatment? You start with cefotaxime, or you start with IV fluoroquinolone, or if there is a very mild case, then oral fluoroquinolone, right? So any third generation cephalosporin will help, cefotaxime will help, IV fluoroquinolone will help. But if patient has already received IV fluoroquinolone earlier, then it might not be, very much of benefit. So this was about it. Do you remember about something I told about? Oh God. Don't understand how to use this. This table we were talking about. So yeah, stages of hepatic incap, just revise once. So stage 1 is general apathy. Stage 2 is I want to sleep. Stage 3 is stupor, hyperreflexia, extensor plantars, and stage 4 is coma, 4 letters coma, right? So yeah, we were talking about this, we were at this. So yeah, I've told you about all of this. Initial treatment I've told you. So how much do we give cefotaxime? So if we are giving cefotaxime, then we give 2 gram TDS. 2 gram TDS. And also there is one thing that I have also asked all my gastro, consultants also, that is it so? But it's not. So in TINTINALLIs it is mentioned that we have to give IV albumin. How much? We have to give 1.5 gram per kg on diagnosis on day 1 and 1 gram per kg on day 3 if there is evidence of AKI, which means that for our lab creat is more than 1. So this thing is going to reduce renal dysfunction, right? It reduces renal dysfunction, and also it reduces mortality. But can you just figure out that such huge quantity they are talking about already, right? So just imagine that they're talking about if patient is 60 kgs. So if you count 1.5 gram per kg, it comes down to 90 grams. And 90 grams mean one bottle is 100 ml, which is 20 grams. You want 90 grams, which means that you will have to take 4.5 bottles, which is equal to 450 ml. Already in liver disease and in ascites, we are taking the patient on fluid restriction. And in a fluid restricted patient, if you give 450 ml of fluid, he'll definitely land up in volume overload. What we have seen in, like what I have observed here in our ER, we give maximum 2 bottles, which means maximum 40 grams of albumin in a day, in one day. That is all. Not more than that. Never, ever. Not more than that. So yeah, this is something that I found different from what we are actually practicing, because I've already asked my consultants also that, sir, is it? So they've also agreed to it that yes, it is mentioned in the guidelines, but for Indian subpopulation, for Asian subpopulation, it's very difficult because of the lean built height, lesser height, so it's not like that for us. Now let's talk about hepatic incap. We've done SBP. Now we're talking about HE. So stages of HE I've told you 1, 2, 3 and 4. 1 is generalized apathy. 2 is I want to sleep, increased sleepiness, increased lethargy. 3 is stupor and 4 is coma. So this was about it. It is poorly understood phenomena. It is because of the accumulation of nitrogenous waste products. Whenever a patient presents to ER in HE, it totally suggests that the liver is no longer able to metabolize. Liver is no longer able to metabolize usual supply of wastes, or you can also say that the supply has increased. Yeah, but that is very uncommon because already patients are on protein restricted diet. So I do not think that that would be the reason. The more common reason is that liver is no longer able to metabolize, right? Now there are few things that can reduce liver metabolic capacity. What are those things? One is constipation. Second is glucose. So if it is hyperglycemia or it is hypoglycemia, it is going to decrease the liver metabolic capacity. Alcohol withdrawal. If a patient is drinking and suddenly goes into withdrawal, it is going to reduce liver metabolic capacity. And sepsis, of course, any kind of infection is going to give so much of load, so much of stress to the body. So these 4 things are known to reduce the liver metabolic capacity. Metabolic capacity. This is about it. So after tips, transjugular, intrahepatic, portosystemic shunting, if you all must know. So after tips, HE is the most common complication, right? Now, if you anytime add or anytime you remove any antibiotic from the ongoing regimen, what happens is the intestinal flora gets changed. The intestinal flora or bacterial flora, it gets altered. This can also precipitate HE, right? Now, asterisk. What is asterixis? When you ask the patient to hold arms straight up and extend, patient starts to flap the hands, right? Patient starts to flap the hands back and forth repetitively. That is known as asterixis. Also, if you are unable to extend, like if the patient is not able to extend his hands, then what would you do? What is the next best thing that you can do? You ask the patient to extend the tongue outside. And when the patient extends the tongue outside, there is back and forth movement of the tongue also. That is also part of asterixis. See, whenever there is HE grade 1 and 2, it can be managed on OPD basis. But whenever it is grade 3, equal or greater than 3, patient has to be admitted. Mostly it is an ICU admission, right? See, HE is a diagnosis of exclusion. HE is a diagnosis of exclusion. Why? Because whenever a patient comes with stupor, with coma, with increased lethargy, etc., that time you have to first get an NC-CT head. Why? Because CT head will tell you about ICH, right? So whenever there is intracerebral hemorrhage, because why? Because in end stage liver disease, there is so much of, deranged INR that we do not know. Deranged INR that we do not know what to do. So patient can be in HE also, but the more probable or the more common reason for stupor, for lethargy is ICH. So first we have to rule out ICH, and if that is normal, if the CT head is normal, then you diagnose the patient as HE, right? Now, there are few things which mimic HE. Meningitis can mimic HE. Sepsis can mimic HE. Renal failure can mimic HE. Electrolyte imbalances like sodium, hyponatremia, and AMS due to some toxicity like benzodiazepine or opioid toxicity can also mimic HE, right? So this is about it. What is the treatment for HE? See, what is the cause of HE? There is so much of nitrogenous waste which is unable to be metabolized by liver. That is why the patient nitrogenous waste is crossing the blood-brain barrier and causing osmotic effects, which is leading to altered mental status. What do? You reduce the nitrogenous waste. How do you reduce the nitrogenous waste? By 2 things: increase metabolism or increase the metabolism, or you can reduce this thing, intake of nitrogenous. So what do? You ask the patient to go on protein-free diet, right? Reduce the protein intake. Also, you can reduce the production. Why? How? By reducing the bacterial activity in our gut, right? So that is the two things we do. What do we give? We give lactulose, loose. You know, there are two things. There is loose syrup and there is enema, retention enema. So this syrup, see, first of all, what is lactulose? Lactulose is a disaccharide. Does it get absorbed in the body? Huge no. It does not get absorbed in our body. It is minimally absorbed in the bloodstream. What happens is this lactulose, it gets converted to lactic acid in our gut. And when this acid becomes, it makes the environment acidic. So the environment becomes acidic. This acidic environment traps the ammonia. How does it trap? Very easy thing. Acid plus base is equal to salt. We know that is equal to salt. So we are giving acid. Base is our ammonia and it forms some salts. Right? So it becomes neutral basically. So when it becomes salt, it becomes, precipitated. It precipitates and then it comes in our stool, excreted in the stool. So that is how loose works, right? So ammonia reduces by 50% by lactulose, and you can also give per oral, that is loose syrup, or you can give per rectal also, right? So when you give per oral, you give 20 gram diluted in 1 glass of water, diluted in glass of water. And enema, you keep it for 30 minutes. Keep it minimum for 30 minutes. Retain it for 30 minutes. This is the first line of treatment for HE. Second is what? Rifaximin. Rifagat, 550 mg. It is very best, best tolerated. But the problem with this is that it is expensive. Then what is there? Neomycin. Neomycin was given earlier, but since it is both renal, like nephrotoxic and ototoxic, so now it is not being used, right? Vanco can be given, but it is rarely used because it is kept for, pseudomembranous enterocolitis. And metrogel can also be given, but it is also kept. Now, next complication is hepatorenal syndrome. Then we have to read about coagulopathy, hepatic failure, non-alcoholic fatty liver disease, genetic and autoimmune liver disorder, pre- and post-hepatic venous thrombosis, special considerations, medication dose adjustment. All of this we are going to complete in next class. That is going to be part 5, unexpectedly, but it is a large chapter, so I had to go through this once. So this is all for today, and we will continue this in next lecture, and we'll start with hepatorenal syndrome and we'll hopefully complete it in the next class, right? So thank you very much for watching. Stay hooked.